Hi, my name is Sakina Alston, and I'm here with Christy Bullock, and we are in Nursing 581 with Dr. Foreman. Our assignment is to discuss a healthcare team that we would create, our ideal healthcare team that we would create to keep us safe. And so we're going to touch on a few components that we think would be on every basic team, because each team is going to be different for every person and what their priorities are as far as keeping them safe, and also each illness is going to have a different team. But basically, there will be a few things that will be on every team, and some of the things that we've come up with are one technological system that all the healthcare providers on the team would have access to. One with a pharmacist that's going to oversee and review all of the medications for interactions, an IT department, also the digital technologies that it would take for a person to care for themselves in the home, and how that data would be uploaded to the chart or the system that all the healthcare providers have access to, and also a financial component, because we know that the costs of healthcare are just getting higher and higher, and in order to maintain our health, we also need to keep our money safe, to keep us safe. So I'm going to start. So those are the topics. And then, so I'm going to start by saying that I think one of the key things that just has to be there is that the system and the patient, so the chart and the patient, need to be one, and it needs to be an electronic system, and all of the healthcare providers need to have access to the system, and they need to order everything, the whole treatment, through this one system, so that the system has built-in checks like the Swiss cheese check, so that all the holes will, if they try to line up so a mistake can happen, the system will alert everybody that has access to the chart. How will people have access to the chart? How will all of that information be protected? And Christy can talk about how they'll have access.
Yes. In these multiple meta paradigms of nursing, it is important that, as far as the nursing aspect goes, that we see the implementation for a higher technology of standard of care for this access to electric health records, the EHR, is protected. So we're going to start with the SDLC model for the process for planning, creating, and testing and deployment of this information system protection. So before I can enter a chart, because we want to protect this important security, because if it's breached, it can cause such havoc, we want to make sure that the standard is retinal scanning. We know that if that's going to be implemented, even on the smallest of community hospitals, not to mention a large university scale hospital, that's a big undertaking. So for example, if we're going to require this retinal scanning, which should be the easiest of the biometrics, you know, with the fingerprint, it's messy, it's reproducible. Eye scan is clean, relatively speaking. So we have to bring in a group that does this work. We have to make sure it's economically feasible. So we're planning. If we have 1,600 employees, we have to get every bit of those employees rounded up. We have to scan their retina with the group that's come in to do this. We have to create the application specific to our electric health record and our software that's currently in place. We have to make sure that we test this. Our nursing informatics nurses are going to be very busy during this time. We've got to make sure that we bring in extra people during this time. We've got to run system checks. This takes time and it takes money. But it's all for the cause of making sure that our data is secure. And to deploy this is a rollout. Everyone knows when they went to Epic, or when they went to a different kind of software recently that's integrated with Obamacare or affordable health care, that this is important, that everything talks to one another, that the interface is in place. So the rollout of this isn't just going to be a one-day thing. It's going to have to catch weekend people, night people, evening and day, people that are on vacations. This is a long deployment of at least 2 weeks. That's going to be people coming in and out, and it's going to be people that aren't able to use it all the time. What about people that have special needs? So that's a whole different thing. So that's just to protect the data that we're here to put into the patient's chart, which is that seamless chart, the avatar that we've spoke of. Sakina, going from this point forward, I would love for you to talk more about the interdisciplinary part of that before I go on to my last little part. Is there anything that I've missed on that last part that you would like to
just
touch on?
I would say,
I'm sorry.
oh, I'm sorry, I'm hearing kind of an echo of myself, but you didn't miss it. Everything that you said about the retina scan, I think, is very important, especially with the high-tech laws. Like, there's laws that go along with the storing of electronic private health information. And so
Yes.
the retina scan will, the high-tech laws have built in where you can get money. They will put money into companies that can provide a safe storage for people who are going to use meaningfully people's healthcare information. So when we start to put everybody's personal information online and into the cloud per se, high-tech laws, we'll have companies, which I'm not sure if you're going to talk about that soon, but like the iTech people, as far as part of the team, iTech, I shouldn't have said that. I mean IT people.
I knew what you meant.
Monitor the high-tech laws and make sure the system that we have follows those laws to keep everybody safe from litigation, as well as safe from any kind of healthcare problems.
Right.
As far as the people who would be on this team. So we have a system, and they're going to have access to this system, and we want them to have retina scans so that we know who they are and we can find them, and nobody that shouldn't be in the chart will be in the chart. And all of these people are going to order any treatment that they have through this system. So they're going to be a pharmacist. They may be whatever kind of physician, your primary care physician. You know, if you're female, you may have to have a gynecologist or some kind of special female doctor to make sure that all the care is very, very specific to each person. It's very individualized. Like I said, it's going to be a basic shell, so I don't necessarily need to name every type of discipline that's going to be involved, because if you have a bone issue, then you'll have an orthopedic doctor, or you may have, a surgeon, but it's the way that they're going to access the chart that makes the difference. That's going to keep us safe. And it's also the way that the records are going to be protected, and the way that the system is going to check itself. And so personally, this is just, on my team, no matter what was wrong with me, I would want some kind of holistic or alternative healer, somebody who would be checking, just the most natural way to treat me. And they could work with the pharmacist, and the pharmacist may order a medication, and they have to check with the alternative doctor if there's any way that we can fix this problem naturally. So they would be working together. So there would be subgroups within this chart working together. So many, many disciplines, not all just healthcare. Like I said, there'd be the IT person, but then we also need a financial advisor who's going to work and review all of the sources for payment and all of the different options for a certain treatment. They would be busy, just as busy as any of the healthcare providers would be, looking at all the different ways to pay, because we need to keep ourselves financially safe in a healthcare environment or climate that we're in right now. Nobody has any money, and everything is very expensive. And illness is chronic a lot of the time. And if your money runs out, then no matter what kind of system you have and what kind of treatments are available, if you can't afford them, that's not going to work. So all of these people would be working together. So physician orders something, or then that gets checked with the pharmacist, the holistic doctor, and then also the financial advisor is going to check and see what's the best financial way to get that done. Then you're going to have the IT people protecting those records, and the patient also has as much access to the chart as the physicians do, because it's about themselves, and the patient is going to be patient-centered. So what patient-centered, and the avatar that Dishman talked about, an avatar in his TED Talk in 2013, and the avatar would be like the chart and the patient being one. It would be like a Sims character, like a simulation. So when something is ordered, the reactions would show up on the avatar first before it even hits the patient. So that's like a built-in safety check. So if you order a medicine and it's going to interact with some other medicine that the avatar is already on, you'll get to see, all of the healthcare providers will get to see what the ramifications of that are before it actually rolls out on the patient. There was a thought I just had in my head. So avatar.
How about the specifics? How about technology getting so specific? And maybe you can think about that while I wrap this up really quick and come back.
Okay.
But the 3D printing, Hudson 2013, with specifics to patients, the less invasive and more accurate diagnostic tools are going to be extremely important with this emerging technologies. How 3D printers can specifically print out non-invasive blood pressure cuffs, O2 monitors that are specifically made for a patient. No more reusable one-size-fits-all. It's going to be just for you. It's going to be extremely important. No more A-lines for people that really don't need them. Only the critically ill will have them. And these bioprinters with bio-ink, they will all be made. And this is awesome technology used for patient care, like that avatar, that seamless avatar of the patient. We're going to be getting the best quality data for these patients. It's going to be extremely sensitive information. And of course, all this is uploaded into that patient chart, that EHR that is completely seamless. It's always changing and flowing, and it's protected. How do you feel about that, Sakina?
I definitely feel that will be a way to save money. I think in the beginning it will cost money, but if you can have a 3D printer make a blood pressure cuff instead of having disposable blood pressure cuffs that have to be maintained by a durable medical company, durable medical equipment company, then it's going to save money in the long run. And I've noticed that you can take data from those things. Like if you have a blood pressure cuff that's taking blood pressures in the home, sometimes they can have like an SD card or something like that implanted in the device, and that can be used to extract data, like the trending in the blood pressures or whatever it is. And then that can be used for research that will keep not only the current patient safe, but also will notify healthcare providers of information that will keep other patients safe, because it's a way to store and analyze data. So I really like that idea. And then I was going to say, when we have these one systems, when I say one system, I mean that chart with the healthcare providers, that's a shell that everyone's going to join for each case. They will, there was a part of the assignment that said, how will mistakes be handled? So in one of the TED Talks that I watched, I think it was the one with Scott from 2010, he said that we don't want to, when someone makes a mistake, we don't want to discipline them, because I guess it scares people and they do not improve, and it doesn't keep anyone safe, but you do want to address the problem. So when you have a system like that is recording data and it's storing data, then you have a very good place to start, where you can do like a root cause analysis of what phenomena is causing this error. And also it tracks which errors happen the most or the least. And so you know how to prioritize by reviewing these records. So I think that if there is an error, the person who made the error, as well as anybody who was in a position to catch the error and didn't catch the error, they should get together and they should create a presentation that is based on like a root cause analysis of how this happened. That presentation would be stored in the system, like the chart. So not only in the patient's individual chart, but you could take patient identifiers out of it and just put the root cause analysis in the chart. So then you would have a library of root cause analysis for certain problems that would help keep everyone safe, because they would be used as a resource for all healthcare providers. And they could be, because it's an electronic record, it's like certain topics. You type in the topic that you're dealing with on this certain patient, and then all these resources will come up and you'll be able to read all of these root cause analysis about how to keep people safe.
I think that is an awesome idea for a Just Culture database of root cause analysis. That's really great. All right. I
So,
think we satisfied our 10 minutes. What do you think,
I
Sakina?
think so. I think so, and I hope we covered everything. So
I have definitely covered my end, and I know you've more than covered yours.
all right, well, I'm happy. I'm happy about that. Sorry about that, guys. All right. Thanks.
Thank you, Sakina.
Bye-bye.